Next, Magnus Ohman is joined by Dr. Robert Yeh, Director of the Smith Center for Outcomes Research at the Beth Israel Hospital in Boston, Massachusetts. They cover individualizing treatment duration of dual antiplatelet therapy after PCI, analysis of the DAPT study.
Welcome to ACCEL.
Thanks for having me.
So, Rob, you presented a late-breaking clinical trial here, which is very relevant for all interventional cardiologists, but even beyond that point because it involves dual antiplatelet therapy. So we're very much looking forward to hearing your thoughts about this. But before we get into your results, maybe you can just remind the audience a little bit about the trial design, because it's not the typical trial design.
Sure. In the DAPT study, patients who had received an FDA-approved drug-eluting or bare metal stent and then had subsequently completed 12 months of dual antiplatelet therapy without a major ischemic or bleeding complication and had been adherent to medical therapy during that time were randomized to continue thionopyridine therapy for an additional 18 months versus receive aspirin and placebo. So dual antiplatelet therapy versus aspirin and placebo for that time period. And the primary endpoints were dual primary endpoint of stent thrombosis and major adverse cardiovascular and cerebrovascular events. And the primary safety endpoint was Gusto-defined moderate or severe bleeding.
And the results, when they came out last year or so, were actually a little bit mixed because they gave some signal to benefit and some signal to harm. So walk us through that a little bit.
Yeah, there was. Patients who were randomized to continued thionopyridine therapy did have reductions, significant reductions in stent thrombosis and myocardial infarction, and that was counterbalanced by an increase in Gusto moderate and severe bleeding. And then there was this nominal signal of an increase in all-cause mortality in the drug-eluting stent patients who were treated with continued thionopyridine. So it's exactly what you stated. There's potential benefit, and there is potential harm too, and that really is the motivation for this study that we're presented here at the AHA.
Of course, it's hard when you write guidelines and recommend therapies when you get this mixed message. So it gets to the individualizing treatments. So you set out to understand how we could individualize the treatment decisions based on the data from the DAPT trial. So tell us a little bit how you went about that.
It rests first on the assumption that there is heterogeneity in the population, that there are individuals who are more likely to derive benefit, there are other individuals who are more likely to be harmed from thionopyridine therapy, and then we set out on a modeling exercise to really tease out who those patients were. It's complicated, of course, because it's two endpoints. It's bleeding and also ischemia, and so really I think the fundamental step forward that we think we provide here is the creation of a risk score which can simultaneously account for bleeding risk and ischemic risk.
In general, as these scores for bleeding and ischemic events have been developed in all kinds of different clinical settings, post-MI and post-PCI, generally speaking, many of the things that drive bleeding also drive ischemic events. So how did you sort of come to separate those out?
Well, it turns out in our analysis that there were those factors that predicted both ischemia and bleeding. However, there were other factors that had a much stronger effect on ischemia and a negligible effect on bleeding, and still other factors that more strongly predicted bleeding rather than ischemia. It's the discordant prediction of those events, which are the variables that actually were retained in the DAPT score. Those variables that predict both ischemia and bleeding actually fell out of the model because they did not actually help one determine whether or not a patient would benefit or be harmed.
And you had a large sample size to run from, right?
Yeah, we have nearly 12,000 patients, randomized patients, and so we have quite a large number of events, both ischemic and bleeding, to create these models.
Great. So tell us a little bit about what I would call these discordant variables, those that really drive the balance between ischemia and bleeding.
I think one of the largest factors was, of course, age. Age had a much stronger impact on bleeding than it did on ischemic events. So as you went up in age, for example, age greater than 65, greater than 75, you were much more likely to be harmed by dual antiplatelet therapy than benefit. Of course, there were also factors that predicted benefit from an ischemic side, and those were factors related to cardiovascular risk and procedural variables that actually have been described previously.
So tell us a little bit about the clinical variables, because as physicians try to prescribe and weigh up the risk-benefit ratio, which clinical factors now for reducing ischemic stent thrombosis and MI predominantly, I presume, which ones are those?
As one might have expected, the presentation with a myocardial infarction at the index procedure was a predictor of benefit for longer duration of therapy, as was a prior history of myocardial infarction or prior PCI. diabetic patients, patients who were actively smoking at the time of enrollment in the trial, those patients also benefited from prolonged therapy. Finally, there were procedure-related variables such as stent diameter less than 3 millimeters, vein graft PCI, as well as receipt of a paclitaxel-eluting stent presented an increased risk. And finally, one variable that I omitted, a prior history of congestive heart failure or low ejection fraction.
So the clinical variables are everything that we think about. So if you came in with a STEMI originally, like that's now 12 months before they were randomized, diabetes, which we know are high prothrombotic risk, those who are smoking, another high thrombotic risk. It all makes sense here. And the heart failure, low ejection fraction. So it all fits together. How do you now, in sort of practical term, turn this around? Obviously had developed a score for this.
That's right. We have developed a simplified integer risk score. The range of the score is between -2 and 9 based on either 1 or 2 points for these factors. And we find when we look at actually the randomized outcomes as stratified by this score that patients with scores of less than 2 were much more likely to be harmed by continuation of thionopyridine therapy, whereas those with scores of 2 or more were much more likely to benefit.
So this is exactly individualizing treatment. So you came through with the promise, individualizing treatment. Well, we're actually looking forward to seeing the score published so we can actually all use it. It's a terrific opportunity for all of us.
Absolutely. And I will say that at the time of our presentation, we have available now the DAPT score calculator. So we have created a web application that can be accessed by all clinicians to facilitate use of the score at the DAPT study website. So our final takeaway is that we've created a risk score, the DAPT score, that uses common clinical variables that may help clinicians decide who should and who should not be treated with extended duration dual antiplatelet therapy.
That is terrific. Thank you for participating with us.
Thanks very much for having me.